A to Z of dental implant procedure. Before undertaking an implant placement, a thorough clinical evaluation of the patient's general and oral health is performed. Particular care is taken in high-risk patients in consultation with the general physician. Any dental issues like fillings, root canals, and scalings are performed prior to an implant surgery on clinical, radiographic evaluation, and 3D scans. The need for bone grafting due to lack of inadequate bone available for implant osseointegration is required. It is performed at the time of extraction of the offending teeth or at a later date, about 3 weeks after healing of the extraction sockets. But usually this step is completed well before the implant placement procedure to allow for bone graft to fuse with the existing bone. At times, soft tissue graft or bone grafting may be needed during the implant procedure as well, due to some inadvertent bone or soft tissue perforations during surgery, especially in the jaws with weakened bone quality. Implant surgery entails the following. Phase 1 is implant selection. The success of an implant depends on its osseointegration with the jaw bone, and this in turn depends on the implant's primary and secondary stability. What is primary stability and secondary stability? Primary stability refers to the mechanical engagement and interlocking between the implant interface and the jawbone when the implant is inserted. It is the mechanical engagement. Next, what is secondary stability? It offers further stability to the implant biologically by bone regeneration and remodeling. Hence, new bone is formed around the implant. Primary is our mechanical engagement and secondary is further जो bone regenerate and remodel हो रही है. The osseointegration of implants depends on 4 factors. Successful integration depends on combined interplay of these factors. First is implant length. Long implants provide more surface interface between implant and the bone, thereby improving the implant's initial stability. Lengths range from 6 mm to 16 mm. There should be at least 2 mm of space between implant apex and any vital structures like mandibular nerve canal. Implant length is determined by the height of alveolar bone available, and if the height of bone is inadequate, it can be increased by bone grafting to increase the success rate. Next is implant diameter. It usually ranges from 3 to 5 mm. Greater diameter affords better distribution of load on the implant. However, at least 2 mm of buccal and lingual bone around the implant should be left intact for optimal osseointegration. Like implant length should be like long implants में more surface interface between implant and the bone, thereby improving the implant's initial stability. ठीक है. Implant diameter, it usually greater diameter affords better distribution of load. Then bone quality. Bone is classified as type 1 to type 4, with type 1 being the best quality compact and cortical bone, and type 4 being the poorest quality with a greater concentration of cancellous or spongy bone. These types are referred to as D1, D2, D3, D4. The interior mandible usually contains D4 type bone, that is the poorest quality with a greater concentration of cancellous or spongy bone. Posterior maxilla has D4 type bone and presents as greatest challenge for implant placement. Interior mandible and posterior maxilla. The bone quality suffers further atrophy during long periods of edentulous condition. Next, we have to take in account is implant shape. Endosseous implants are cylindrical or tapered. Also, they may be threaded or non-threaded. Threaded implant has a screw type configuration. They can be self-tapping or non-self-tapping. Self-tapping implants have a cutting tip and cut their threads into the drill hole as they are screwed into. Non-self-tapping types are non-cutting and need a tap to cut threads into the pre-drilled hole in the bone. The best configuration with adequate bone available is a cylindrical self-tapping implant. Self-tapping is they have a cutting tip and cut their threads into the drilled hole as they are screwed onto. However, in D4 bone quality, tapered implants have shown more favorable outcomes as they reduce the stress on the bone while being screwed into due to their conical shape. To summarize, depending on the quality and quantity of bone available, the implantologist will select the right implant for you. Next is pre-implant palliative therapy. The patient is prescribed the following medications 1 hour before implant surgery is prophylactic antibiotics, 1 gram amoxicillin, alternatively 300 mg clindamycin if allergic to penicillin to minimize the chance of post-operative infection, analgesics and anti-inflammatory drugs that is diclofenac or paracetamol, oral or subcutaneous steroid injection to reduce post-operative swelling, and chlorhexidine mouth rinse. Then we come to anesthesia. If the implant is to be placed in the maxilla, infiltration anesthesia suffices. If it is in the mandible, then inferior alveolar nerve block anesthesia is administered. If full arch implants are to be placed or concomitant procedures like sinus lift procedure is to be performed, intravenous sedation along with local anesthesia is preferred. Then we have to oral mucosa flap reflection. After anesthesia is achieved, incisions are made in the sterile environment and buccal, front facing and liqual palate and tongue facing mucosal flaps are reflected to expose the alveolar bone. Then once oral mucosa flap is reflected, then we do the pilot drilling. Drilling a hole in the bone, the size of which is predetermined according to the size of implant to be placed, is done. The initial hole is drilled with a pilot drill. It makes the site of drilling and a hole is made partway through the entire length to be drilled. The surgeon may use a small round burr before using a pilot drill to mark the site of the implant. Drilling should only be performed under a constant steam of chilled saline, so heating of the bone is prevented, which can cause bone necrosis. In tight spots where vital structures are adjacent like a mandibular canal or a maxillary sinus, a periapical X-ray is taken with the drill in position to double check the direction of the osteotomy. Osteotomy means cutting, modifying or moving of the bone. If the surgeon has wavered from the right direction, he can correct the angulation at this point. The pilot drill is then used to drill a hole into the entire depth of the bone and length of the implant. Once the pilot drill has done his work, then we come to osteotomy widening. After pilot drilling, a series of osteotomy widening drills are used as in a sequence of increasing diameter to attain a diameter 0.3 to 0.8 mm, which is less than the diameter of the implant. If the quality of bone is good, that is D3, D4 bone, then hole should be about 0.8 mm less than the implant diameter. So the implant screws in snugly into the tight space with primary stability. If the bone is D1 or D2 type, then the drill hole should be about 0.3 mm less than the diameter of the implant, such that implant screwing does not put undue strain over the bone. So then we have done with our widening. Then we start with the implant screwing. Once the implant osteotomy is ready, the implant is unveiled by the surgeon from its sterile packing, fixed into the implant ratchet or rotary handpiece. Strictly adhering to the sterilization protocols, the implant is screwed in a clockwise direction. If some resistance is met, the screwing can be stopped for letting the adjacent bone expand a little. Then the screwing of the implant in the clockwise rotation may be resumed until the whole implant is seated. The top surface of the implant, called the implant platform, should be flushed with the bone level in the D1, D2 and D3 quality bones, but should be submerged 0.5 to 1 mm in D4 type weak bone to prevent any occlusal pressures on the implant during the next few months of osseointegration. In areas visible on smiling and talking, the implant platform should be 2 mm below the cemento-enamel junction of the adjacent teeth. This allows for a more natural appearing soft tissue emergence around the future implant prosthesis. Once the implant is placed, its top surface is covered with a cover screw or a healing cap. Now, what is the healing cap procedure? Healing cap is an attachment for the implant platform which sticks out of the gums even after the soft tissues are sutured. It removes the need for a second minor surgery to expose the implant at a later date after osseointegration. For planning implant prosthesis, it is preferred in cases where there are one or few implants to be installed and the bone quality is good, which may not be negatively affected by chewing loads. Then, cover screw. This attachment is short and submerges under the gums once the soft tissues are sutured. This warrants a second minor surgery for implant exposure at the later date. For planning the prosthesis over the implant, it is preferable in cases where bone quality is compromised or bone grafting has been done due to implant placement procedure and any occlusal load on the implant is undesirable. So either we can go with the cover screw or with the healing cap. Next is soft tissue flaps suturing. Once the implant and the covering is in place, the flaps are stitched back with resorbable chromic catgut sutures or non-resorbable sutures. The latter requires suture removal after 7 to 10 days. The suture should be tension-free for minimal traumatic healing. Then we sometimes have to give the temporary prosthesis. If the implant is clearly visible on smiling and talking, then a temporary crown, bridge or partial denture is fabricated in the clinic itself to save chairside time. Then the post-operative instructions are: the patient is asked to keep the mouth closed for at least 1 hour. Cold packs on the facial skin above implant area are advised for the first 2 days to minimize inflammation and post-operative swelling. Hot packs are advised over the facial skin after 2 days to diffuse any inflammatory constituents collected in the soft tissue at the implant site. Next we come to the phase 2, that is after osseointegration of implant. It takes around 3 to 4 months for mandibular and 5 to 6 months for maxillary implants to get osseointegrated. This is determined on radiographs. Depending on whether a cover screw or a healing cap was placed, following actions are undertaken. Cover screw: if it was a cover screw, then a second minor surgery to open the site of the cover screw is performed and the cover screw is removed. It is then replaced with a healing cap and the gums sutured. A tissue is allowed to heal for approximately 2 weeks. After 2 weeks, the healing cap is removed and replaced with an abutment screw. An impression is obtained of the abutment screw and sent to the dental laboratory for fabrication of the final prosthesis, crown, bridge or denture. Then the healing cap. If the healing cap is placed, then the second surgery is not needed as the healing cap is already exposed in the mouth. The rest of the procedure is similar.